Hello and welcome to JAMA Network Open Conversations. I'm Angel Desai, Associate Editor for JAMA Network Open. Today we are speaking with Dr. William Small and Dr. Adam Sorensi about the potential of large language model-based responses to patients' in-basket messages. Welcome to the both of you. To begin, can you please introduce yourselves?
Sure. I'm William Small. I'm honored and excited to be here. I'm a hospitalist and clinical informatics fellow at NYU Langone.
And I'm Adam Sorensi. I'm the medical director for ambulatory informatics here at NYU Langone, and I'm a primary care practitioner.
So this was a really interesting study and very timely, both from the perspective of medical applications for generative AI, but also, of course, with the topic of electronic health record inbox management. Can you discuss a bit about its background?
Sure. Particularly since the COVID pandemic, when everyone got sequestered away from being together in person, patients were sending a much larger volume of in-basket messages to their primary care physicians and associated staff. And, those professionals were already sort of overburdened by all the EHR tasks they had to perform. And so each additional message only added to that burden.
There's a tremendous demand for care now, right? Post-COVID, we have aging populations, we have a shortage of providers, and we have increasing documentation requirements. So docs are pretty much overworked and their schedules are booked and burnout is real. So to me, this is a perfect opportunity to use a technology that is now becoming available to us to be able to try to offload some of the work for our docs.
It's a really great, introduction to this paper. Can you tell us a bit about what you did in the study?
We surveyed 16 primary care physicians from across our institution and presented them with pairs of patient messages and either the actual human response that was sent to them or an AI draft that was generated in the background that wasn't viewed or used by any clinicians or their staff. And we asked them three basic questions about each response. First, whether they would use this draft to begin their response to that message. Next, whether they thought the response had high quality information content, which we defined as sort of being relevant and accurate to the patient message. And then third, whether the information itself was communicated appropriately, which we defined as, having an appropriate tone, being empathetic, things like that.
Perfect. And what did you find?
So we found that they were roughly equivalent on all the questions that we asked of the primary care physicians, and that the AI responses actually outperformed the humans with regards to the way the information was communicated. And then we did a secondary analysis of the content using sentiment analysis and computational linguistics techniques, which is a fancy way of saying we looked at all the different words in sort of predefined categories, tried to categorize each response type.
I think one of the findings that was very interesting to me was the frequency of insufficient professionalism noted in the healthcare providers' responses versus generative AI. Any reflections on that?
I think to me, it kind of underscores really the provider time, right? As I said, at the end of the day, I'm seeing 20, 30 patients. I now have to respond to my phone calls and I now need to respond to my patient refill requests. And then I also need to respond to the messages. So as much as we'd love to put, that extra effort into it and to have a beautiful, empathetic conversation with our patients, we just really, when it comes down to it, want to get out and answer the question. And so I think you'll see that a lot where we as clinicians we're typically just answering the question really, really quickly, right? That's how we're doing it right now. It's the bare minimum. Whereas if we hand off some of this to a bot, there's an opportunity to, insert some empathy into there and be able to have a more productive conversation with the patient through the system.
And I think one of the keys about that component was sort of the way we structured the study, which was you don't have any context. You really just have the patient message and the response. And so I think in a real world setting, they might be deemed more professional if you had an understanding of what the actual relationship was like between that clinician and their patient.
That definitely makes a lot of sense. I'm wondering if we could take a step back and if you could just speak more broadly about this work in the context, I think, of the explosion of interest in generative AI in the medical field. Do you see this type of application, so in-basket response, for example, as a realistic path forward or as part of a partnership between potentially the medical field clinicians and these types of applications?
I absolutely think so. To me, we're at a cusp of a paradigm shift here in how we practice medicine, right? We have, over the last 20 years, docs have been, using the electronic health record, putting data into the system, lots of documentation burden. But now we're at a point where we're beginning to see, the beauty of what these tools can do, right? So it's able to take that information. Now we're able to use it to summarize visits. We're able to use it to, with new technology now, the ambient dictation is able to create progress notes for us to draft. So I think there's a lot of technology that's really in its infancy stage that we're starting to see a lot of benefit for. And I think it's just going to explode. And I think it's going to really support the docs going forward. So I'm really excited about this.
And I think where this study fits in to the grand scheme of things is really in sort of like a benchmarking exercise. So we use the standard out of the box prompts to the generative AI model that all institutions get, and that was used to generate responses that were then evaluated. And so from there, we were able to use our data to inform the different changes we made moving forward to try to improve the drafts.
Just to provide some more context, our first iteration of this, our responses, as Will said, we use the out of the box prompt for Gen AI. The responses were very, very verbose, extremely friendly, which is absolutely not a bad thing, but it's just not the physician's voice, right? And so it's really clear when you're maybe writing to a patient and for the last 5 years you have a sentence or two, and then all of a sudden now the patient gets a paragraph. It's just unrealistic. And we want to make sure that it's with the provider's voice. So that was kind of the initial iteration of it. It was a lot of superfluous information. It recommended appointments for lots of things. And that's how the prompt was designed. And when we first rolled this out, that prompt had about a 5 to 6% response rate that providers could use the draft for. So they basically were dismissing the draft 95% of the times. And as Will had mentioned, we've made a number of iterative changes over the last couple of months as we deployed this and scaled this to our clinicians. And part of those changes were, we configured the prompt to say, answer the question as if it's a doc having a relationship with this patient. You want to make sure you're addressing the actual question. Don't push it down the road to another visit. We don't want to recommend visits all the time because that's not realistic. We want to make it concise, but maintain that level of empathy as well. And we tend to, generally speaking, when patients ask requests for medications or referrals, we tend to say, yes, we'll start doing that. And so it starts to answer those questions in the affirmative and say, hey, yeah, I queued up the referral for you, or if I've renewed this medication for you. And so we've made a lot of those types of changes, and we're watching the response rate go up gradually as we begin to refine that prompt over time. And now we're close to a 20% response rate to the messages, where in the past it was about 5 or 6.
Wow. Now, we've talked a little bit about the opportunities that these types of large language models may pose. And I'm wondering if, as a counterpoint, are there any types of messages that you could foresee that would require more complexity than a large language model could potentially offer at this point? And is there the possibility to take that further, that the use of a large language model in this way could either address, in a broader sense, certain health inequities, or could it perpetuate those inequities more?
I think, what it's really going to have a tough time doing is understanding the idiosyncratic nature of each individual and how they approach healthcare, which is really only something that their physician or sort of related staff could understand and use to respond to a message or help sort of drive their care in an empathetic way. With regards to biases, I think we just don't know enough yet about how those biases are presenting themselves. And we have a research team that Adam and I are a part of, led by Dr. Sophia Richardson, to really dig deeper into the content using similar tools that we use in this study, but with more of a health equity lens.
To address your earlier question about large language models, right now, these first generation products that we're using and beginning to develop are really only taking in very basic context into play. So we pass along very basic demographic information. We may pass a problem list into the prompt as well. So it's only going to be able to spit out the info, to provide that context and what it knows. As this develops over time, the systems are ultimately going to be able to pass more of that information to our large language models and say, all right, let's look at all the progress notes that this patient has had or has had written over the last some odd number of months, and now craft a message based on that. And look at some of the tone that docs are using when they write their notes and make a better note, for example, as we look at some of the other tools, or summarize the visits that the patient has had in the interim of seeing, let's say, myself as a primary care doc, and now, I walk in, I can see here's what happened, a concise view of what happened, and it saves me time for reviewing. So I think as we begin to start using the tools to pass more information for that patient background into the model, it's going to develop some better summaries and better tools for us.
Really interesting. Before we wrap up, are there any final thoughts on this study or anything we didn't cover?
And I think the key here is that we only surveyed primary care physicians. And so a lot of our findings are biased towards what a physician might prefer in a message. But really, patients are the ones who are being impacted by the results of these responses. And so a lot of work needs to be done to make sure that the AI responses are adequate from their perspective as well.
And so, from my perspective, I would say there's a lot of exciting technology that's really on the way, and docs shouldn't be discouraged, right? They're burdened with so many different things, and I think we're now beginning to really be able to leverage those tools in new ways that will help cut down some of the work and get them out at times where they can start seeing their family and enjoy their lives at home.
I think those are some really interesting thoughts to end on. Thanks so much to Dr. William Small and Dr. Adam Sorensi for speaking with me today about this very relevant topic.
Thank you.
Thank you. This was fun.
This episode was produced by Daniel Morrow at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.